Afternoon, and thank you for joining us for the SRTR Tools 101 webinar today. And thank you for your patience as we postponed the webinar for a month during the COVID-19 crisis that we are all dealing with. Appreciate you joining us today and making time in your schedules. I do want to welcome you. My name is John Snyder. I'm the director of the SRTR, and I will be joined today on the webinar by my colleagues, Dr. Andrew Way, who is an SRTR principal biostatistician, as well as Dr. Allison Hart, who is our SRTR senior staff for kidney transplantation. They will be sharing with you some of the tools that they have produced for the SRTR, and I will be going over the liver waitlist calculator that the SRTR makes available to the public. I just want to begin by wishing my best to all of our colleagues out at the various transplant hospitals in the nation during this unprecedented time dealing with the COVID-19 situation. I've heard from many of you and understand the unique challenges that this situation is placing on transplant programs. I just wanted to note that the SRTR is analyzing the impact of the COVID situation on the transplant system in the United States. We're working closely with HRSA and with UNOS OPTN staff to analyze the data as quickly as we can. We will be assessing the impact on various transplant performance metrics, OPO performance metrics as well. So look forward to that coming out in the future as the data become available. But just want to wish you all health and safety wherever you are as we get through this time. I always like to begin by just reviewing the mission of the SRTR as established by HRSA, and that is for the SRTR to provide advanced statistical and epidemiological analyses related to solid organ allocation and transplantation in support of the Department of Health and Human Services and its agents in their oversight of the national transplant system. And over the years, we've began to host these webinars as a way to help fulfill this mission, to support the community by offering educational material and educational tools for the transplant programs and the organ procurement organizations to use. Ultimately, we hope will better the field. Today's outline, I will cover our public liver waiting list calculator. Dr. Hart will cover our kidney transplant decision tool that she developed in collaboration with many of her colleagues. Dr. Way will cover the pre- and post-transplant expected survival workbooks. These are workbooks that we make available to transplant programs through our SRTR Secure website to help them monitor their outcomes and do their own analyses with the data. And we will end with a question and answer period. There is a chat box that you should see in your WebEx window. That is where we would like you to enter your questions as you have them. Feel free, if you want to note a slide number that your question pertains to, we'll try to address those as well. So feel free to chat those into us at any time, and we will address as many as we can at the end. If we don't have time to address all of them, we will certainly respond to all of them via. We always like to try to understand those of you in the audience. And so we're launching a poll here. And if you could just go ahead and choose what best describes your relationship to the field of transplant. And I understand that many of you are at institutions where you perhaps have more than one person in the room with you. But just choose the best option here for what describes your participation in the field. This just helps us to understand who our audience is. We want to make sure we're able to see that. So looks like we've got most of the answers coming in. This just helps us as we go to make sure that we're connecting with the right folks and that we are understanding our audience as best we can. And as we're filling this in, just if you ever have any suggestions for us or webinar topics that you would like to hear, feel free to email us at srtr@srtr.org. We always like to hear those suggestions. So we will pull those results, and there's a second poll here, and this is just to gain an understanding of how many people are listening in today. So you should see the poll pop up on your screen, and appreciate if you could let us know. I see we do have 157 current connections into the webinar, which is fantastic. We're just like to understand if we have multiple people on certain connections, just so we get an accurate count of how many folks we're reaching with the webinar. Having said that, we do post the webinars on our YouTube channel, and you can access that at any time following the webinar once we get it. Usually takes us a few days to post them, but you can review this webinar in the future, as well as any past webinars that we have recorded, so that we can hope to continue to grow those. And certainly just let us know if there's a topic that you don't see there that you would like us to cover. We're happy to try to do so. I see that most people are responding just me to that one, which is not a surprise, I guess. Perhaps many of us are working remotely these days, staying socially distant from our colleagues. So thank you for participating in those polls. We always appreciate having the chance to learn who is with us and how many folks we have attending. So I'll jump right in with our contractual requirements. I always like to ground the audience in why we are doing certain things that we are doing. Why are we producing the tools that we're doing? The focus of today's webinar is on tools supplied by the SRTR on our public websites and our private secure website. And the products reviewed today fall under the two following tasks in our contract. We have task 3.4.2, which states that the SRTR contractor shall maintain and improve our websites for dissemination of transplant information to the public and the transplant community. And then this task 394 deals with the tools that we developed. And HRSA has asked the SRTR contractor to continue to develop and provide tools for performance improvement by transplant programs and OPOs. The two tools that we are going to discuss first, the liver waitlist calculator and the kidney decision aid, both originated out of requests from the OPTN liver and kidney committees respectively, asking the SRTR to investigate ways to produce helpful calculators that would help patients understand different outcomes perhaps at different transplant programs around the country. So both of the tools we're going to share with you today try to address that topic. So we will start with the liver waitlist calculator. I like to orient people to our website. If you go to www.srtr.org and you click on that third menu from the left, which is the reports and tools menu, you will see at the bottom where the blue arrow is pointing the liver waitlist calculator. And I'll note right above it is the kidney transplant decision tool. Those are the two tools that we will be discussing in today's webinar. We have done past webinars that have addressed the risk adjustment models and PSR and OPO report issues as well. So today we're focusing on those bottom two, and we're going to start with the liver waitlist calculator. If you click on that, you will be taken to a page that looks like this, that just gives some high-level information about the tool. If you click on the little pie chart there, you will enter the tool itself. And you will be presented with a page that looks like this. And I'm going to walk you through, we hope that the tool is fairly intuitive to use. I will walk you through an example just so you can see the types of information you can input into the tool and give you a little background about each. On the left side of the tool, there are these selector boxes, and the tool is designed to provide the user with likely outcomes of patients that are on the wait list at any given point in time. And so in other words, say a patient is going to list at a certain program and they're curious, what might my outcomes be at certain time points down the road? What's typical for patients at that program? And so we start this by helping the person choose which program is the program they're interested in looking at. Now, we felt the best way to do this was first to let the patient choose a state to narrow down. So the it's alphabetical, and so I'm showing you what it defaults to when you first open the tool. So it defaults, of course, to state of Alabama. Once you've chosen a state, you will see specific liver programs available to choose within the second drop-down box here, just defaulting here to the University of Alabama Hospital. We do allow the user to choose a specific blood type. If the patient does not know their blood type, they can leave this on any blood type. But if you click on the selector box, you will be presented with various blood types that you could narrow your results down to. If you knew you were AB recipient, for example, you could choose AB. The next selector box lets you choose an age range. Now, this tool was designed specifically to estimate outcomes for adult candidates. Okay, the tool is one limitation of the tool is we do not have pediatric data included in the tool. And so the age ranges, you're presented with three options. You can either say any adult age, so that would be any age 18 or older, which is the default. Or if you wanted to select that into the younger adult age group or the older adult age group, we do have a cutoff at age 55. So one of the choices would be 18 to 54. The second choice is 55 years of age and older. And it defaults to, of course, any adult age. The next box, of course, lets you choose your current MELD score. This is given in a bunch of ranges of MELD score, and so the patient would enter in their current MELD score range. And here we are showing a MELD score of 25 to 29. We then allow the user to choose whether we want to limit this to patients with MELD exception scores or not. Okay, and so the default here is to show all patients within that MELD range, or you can choose patients specifically with HCC exception scores or patients without HCC exception scores. And then we allow the user to choose a time period. So these are given in days, and so we allow anything from 30 days up to 365 days post that point in time, but we don't give a continuous range. The user is allowed to choose 30 days from now, 60 days from now, 90 days from now, 180 days from now, or 1 full year from now. So those are the current choices we allow the user to pick. So I'm going to walk through an example just here in Minnesota where we are located. So I've chosen the state of Minnesota. Just as an example, I have chosen the liver program at Rochester Methodist Hospital, Mayo Clinic in Rochester, Minnesota. I'm leaving it on any blood type, any age range, MELD score of 30 to 34. I'm showing all patients within this MELD range, not limited to HCC patients or non-HCC patients. And I've chosen to show outcomes at 3-month periods, so 90 days from this point in time. And then the user is presented with a pie diagram here showing the outcomes of patients at that program. What were their outcomes of those listed 90 days from then. So what we're doing here is we're using a historic cohort of data, and we're looking at not randomly sampled days, but we have sampled certain days on the wait list, and we've calculated those outcomes for all of the patients that were on the wait list on that day. It's 90 days down the road. So you can see here that there were 54 candidates that were included in this analysis at the Mayo Clinic in Rochester on the days that were sampled. The pie chart then gives you the outcomes of those patients. So we see here that 32% approximately were still on the wait list. 54% had received their deceased donor liver transplant, and 15% had died or had been removed from the wait list for being too sick for transplant. Now, if the pie chart is not something you want to look at, the user is allowed to choose the tabular results right next to the graphical results. So the same data that's in the pie chart can be given to you as a table, particularly useful perhaps if you wanted to print out that information. But there's two options there, both giving you the same data. So that's what happens at that program. The tool will give you 3 comparator groups as well. So we give the program as well as the program's local donation service area. In other words, all of the programs in that donation service area. And then we also give all of the programs within the OPTN region, which is the second pie diagram down on this slide here. and then the nation as a whole. And so if you look at the nation as a whole, for example, we see that there were 3,201 candidates that were on the wait list with those characteristics on the days that were studied. 46% were still waiting, and 43% had received a deceased donor transplant. And so those numbers are perhaps helpful comparators to what's happening both within the OPTN region, the donation service area or DSA, and the transplant program itself. So a few key considerations about the tool. Again, we only include adult candidates on the tool. There is a caveat to that. I will say some people have been confused that you will see children's hospitals available to choose in the drop-down list of hospitals within certain states. But this would only be showing you patients that were over the age of 18. Of course, there are patients at children's hospitals that are on the wait list that have passed their 18th birthday. And so if that were the case, those patients would be included, but we are not including pediatric patients in any of the calculations that are available in the tool. The tool does suppress any grouping of fewer than 5 candidates. So if you select a certain characteristic of patient that doesn't have at least 5 candidates at the program, that information will be suppressed, and you will be presented a message saying that there are fewer than 5 candidates with those characteristics. And then perhaps you could broaden out your selectors to hopefully get a cohort of patients that are more than 5. These are actual observed historic data, and I like to make the distinction that these are not modeled data. The kidney tool that Dr. Hart will show you next is a model, modeling the kidney transplant wait list. And when we worked with the liver committee on this, they felt it was a good thing in the liver community to actually just be presenting historic data of what happened on the list. And so what we did was we sampled the wait list on certain days and then just determined exactly what happened to the patients that were on the wait list on those days. And we have the caveat that the tool is intended for informational purposes and not meant to offer advice to candidates or their doctors as to the appropriate treatment for a specific candidate, and patients should always discuss their treatment options with their care providers. We do have a detailed methodology available on the tool. You will see in the selector boxes at the top of the tool, you can go over to methodology. Here it gives more information about the information in the tool. It will show you the exact dates that were sampled for each release of the tool. And we try to update the data quarterly approximately. And so we do update this tool on a regular basis so that it has the most current data available. So the days that are being sampled will advance about once every 90 days. And so if you want to understand the full methodology that's used here, we present that all here on the Methods tab. With that, I will pass the presenter ball to Dr. Hart, and she is going to take us through the kidney transplant decision tool that she has developed. So Dr. Hart, are you?
I am. Can you hear me?
We can, yes. I'm going to pass mouse control to you so that you should be able to advance the slides.
Thank you. And thank you to everyone who is listening. I'm excited to show you the kidney transplant decision tool. It does have some differences, as Dr. Schneider mentioned. From the liver tool, it started in the same place. So it started with a request to make calculators to help patients understand outcomes on the kidney transplant waiting list. And as we talked to patients after developing the initial calculators, what we found was that there is a lot that goes into how patients were understanding and interpreting the calculator output. So it became somewhat more of a decision tool, not just a calculator, as you'll see. And I'll walk you through that. We love getting feedback on this. So please enter questions or feel free to email if there's something that's either confusing or you think is missing, because there may be a reason that we did something, but it may just be that we didn't think about it. So.
Dr. Hart, I'm not able to pass control, so if you just want to let me know when to advance,
Yeah,
I can.
you want to go to the next slide?
Sure.
So you, as Dr. Snyder mentioned, you can get to it from the same homepage of the SRTR.org website, going to reports and tools, and then scrolling down to the kidney transplant decision tool. And on the next slide, I mentioned this a little bit, but this ended up being developed using feedback from 75 patients and physicians, mostly patients. So it ended up as something fairly different from what we started with, and all of the wording in this tool and the graphical presentations were a response to patient feedback. And this was so that we could make sure that we helped patients understand why this calculator was relevant. So it's one thing to show people outcomes, it's another thing to show them what they can actually do to impact those likely outcomes. We were able to talk to a fairly wide range of patients from different places in the United States, different backgrounds, different education levels, to try to make this accessible to everybody. And the idea was that we would put those calculator results into context. So like I said, what can you actually do? Why is this information meaningful? You want to go to the next slide? If you click on that kidney transplant decision aid link, you'll end up on this homepage. And the idea of this was to explain what it was. This was very specifically designed to be something that patients went through with a provider, not something that they stumble on if they're surfing the internet at home or looking for information about kidney transplant. We really heard from patients that they wanted this information in the context of a visit with a provider that could help them understand it. So if they did happen to stumble on this web page, the introductory page was meant to specify that this is something that you would go through with your doctor. Now, if you look at the tabs, the very last tab is calculate your risks, and this was intentional. Again, in response to feedback, what we found is that if we started with the calculator, the patients really didn't have the information they needed to understand why the calculator was being shown. It can be a very stressful experience, and so it worked better to help them understand what decisions they would be faced with and what terms they may encounter, that the calculator will help them make. The output of the calculator for their own likely outcomes on the waiting list can help them understand these decisions better. So if you're using the calculator and you've already gone through those things, you can feel free to skip to the end, but the pages before that are meant to help patients put that into context. So if you want to go to the next slide, we go through each of these pages. Again, what you'll see is a message of the purpose of the tool. And what we found is that patients, even patients who had been through very extensive education from transplant centers, really were still struggling to understand the pros and cons of things even as basic as dialysis versus transplant. So it goes through the pros and cons of dialysis and transplant, living versus deceased donor, high quality versus low quality, deceased donor kidneys, infectious risk, and then the calculator. So on the next slide, you'll see the first page of the decision tool. Again, all of these words came from mostly patients with some input from providers to make sure that it was accurate, but these are the pros and cons from the patient perspective of dialysis compared to transplant. So for example, pros, if you're not a candidate, it will keep you alive. Cons, compared to transplant, don't live as long on average. So again, very bare bones. It's meant to facilitate a discussion, but to guide that discussion to make sure that patients understand what choices they're facing. On the next slide, we look at the pros and cons of living donor versus deceased donor kidney transplant. What do you need to consider to compare a living donor versus a deceased donor? Again, all of this wording came from patients to make sure that they understand the pros and cons of each of these, and then can put the calculator for waitlist outcomes in the context and make these decisions with more information. The next slide. We added this slide in response to a lot of feedback. It was very obvious from the beginning that patients had trouble understanding the difference between kidney quality and infectious risk kidneys. In particular, the idea that you could have an increased infectious risk kidney that is actually very high quality. And so we added this slide to help contrast those two concepts. And then on the next slide, we get into each of those individually. So what do you need to consider when you're deciding whether to accept a high KDPI kidney? Again, the language from the feedback from the patients is that they wanted the same language that the providers were using. So they wanted to see that KDPI language used. And so we have the explanation slide before, and then the pros and cons of a high KDPI versus not accepting a high KDPI kidney. For example, the pro being a potentially shorter wait time because of access to more donors. A con, the kidney may not last as long because of lower quality. On the next slide. So having gone through the quality pros and cons, we shift to the increased infectious risk versus standard infectious risk kidneys to talk about the pros and cons of those. The next slide is basically sort of a question review. This is based on educational theory that we tend to think we understand things until we're asked specific questions about them and we realize we can't answer that question. So these are meant to trigger questions that patients can ask the provider having gone through that information. And on the last tab, I believe, it takes you to the calculator. So this is similar to the liver calculator that Dr. Snyder showed you. You can see on the left side, you input the characteristics of the patient. So for the transplant program, we put Hennepin County Medical Center for this example, because that's where I am. The first thing to point out is that you can adjust for the program-specific transplant rate. So you can show a model that's based on data from that individual program. If there isn't enough data, this is statistical modeling. It'll mostly be a regional effect that you'll see. So you can unclick that if you want to see more just a model based on the region that that transplant center is in, or you can see transplant center specific modeling. And you can see you choose your age, the race, ethnicity, the height and weight just allows the calculator to get a BMI. And if you go to the next slide, you can see the inputs to the calculator. There are a few more things than there are on the liver calculator, partly because the modeling was a little bit more complicated. You choose your blood type. If you don't choose a blood type, it will default to the average. If you know your antibody level, you can put that in. If not, it defaults to the average. How many years you've been on dialysis, and then any additional health issues from this list you would click on. I think, actually, if you go back one slide, Dr. Snyder, you'll see the output on the right. So you can use the slider bar at the top. That was feedback from providers. They wanted to be able to show patients outcomes at different time points between 1 and 5 years. And the calculator gives you the likely outcomes, the probability for having received a deceased donor transplant, having died or been removed from the list because of being too sick to transplant, or still waiting at whatever time point you choose from the time that you enter in this information. Again, as Dr. Snyder mentioned, these are statistical models based on prior data. We do update these models. So these models were just recently updated to reflect the most recent experience. You know, the most important issue obviously was updating these models after the new kidney allocation system, making sure we had enough data after that new allocation system to make robust models. If you go forward, I think 2 slides now. Oh, okay, so there is a close-up you can see of what the output looks like. Again, this output was based on patient feedback. They really understood it best with a simple bar graph depicting the likelihood of deceased donor transplant, dying or being too sick or still waiting. This calculator presumes that you do not have a living donor kidney transplant. So this is really meant to help patients understand what the likely outcome would be on the deceased donor waitlist. The next slide. I've mentioned this before, and hopefully the homepage makes this clear also, but this was designed with social scientists and with user-centered designers and based on patient feedback, that this was meant to facilitate a discussion. This is not something that we anticipated patients to look at alone at home. The approach and what we put on the website would have been different if we were trying to make something that patients could see on their own. So this is really meant to facilitate a discussion. I think it is important to point out that we showed this to dozens of patients and got positive reactions to getting this information. There was a lot of additional insight that they felt like they had gained, really understanding what the likely outcomes were on the kidney transplant waitlist. And even when the numbers looked pretty stressful, and as we know, it doesn't look as good as we wish it looked, they had positive reactions to getting this information. Next slide. I think hopefully you can enter in some questions for me. And like I said, I'm happy to answer any questions over email as well, but I'll hand it off to Andy to talk about the expected workbooks.
Yeah, thank you, Allison. So I will be talking about some of the pre-transplant expected workbooks that we released last summer. So on the next slide, just as a little bit of background, the SRTR contract states that the SRTR shall provide data review tools, expected survival worksheets to assist transplant programs and OPOs in monitoring performance, just as a motivation for some of the reasons of why we're pursuing this. On the next slide, as I'm sure many people on the webinar are aware, SRTR integrated 5-tier assessments for deceased donor transplant and waitlist mortality rate ratios onto the public website. And we specifically emphasize the importance of the transplant rate evaluation to patient mortality after listing. And so an example of that is given on this slide, so this is specific to liver transplant, where we're saying that for liver transplant candidates, the deceased donor transplant rate metric actually has the biggest impact on patient mortality after listing. So on the next slide, just as more background, historically, the SRTR has provided Excel workbooks for transplant programs to perform their own subgroup analyses on post-transplant outcomes. And at the 2018 Transplant Quality Institute, there was strong support for pre-transplant expected workbooks to specifically help programs understand the transplant and waitlist mortality rate evaluations. This was specifically in response to the more prominent reporting of these metrics on the SRTR website. So in November 2018, HRSA gave SRTR approval to develop transplant expected workbooks. And last June, we released for the first time pre-transplant expected workbooks for kidney, liver, lung, and heart transplant programs on the SRTR secure site. So on the next slide is just a screenshot of what these pre-transplant expected workbooks look like. I'm not going to go through how you actually access them. They're on the SRTR secure site, basically in the same area, in the same page as the post-transplant expected workbooks. So you just download the Excel file there. It should open up on your computer and you'll see something like this. So on the next slide, the structure of the workbook is basically split into tabs where each tab has different information. And on the next slide, the first tab, which is the guide tab, actually just provides a big picture overview of the information that is provided throughout the workbook and some of the organization of the workbook. And the tabs immediately to the right of the guide tab, so on the next slide, are some of the evaluation tabs. And these summarize the pre-transplant metrics, both for all candidates and for certain subgroups of candidates. And we're going to talk about what those subgroups are coming up. So on the next slide, the overall evaluation tab is exactly what it sounds like. It only presents the overall evaluations as they appear in the program-specific reports. So the example that we're walking through is just a fake kidney program. So we have an overall transplant rate, which includes both living and deceased donor transplants. We have a deceased donor transplant rate, which only focuses on deceased donor transplants, obviously. And then we also have the overall waitlist mortality rate. On the next slide, the by age evaluation tab is sort of trying to split those evaluations, the transplant rate ratios and waitlist mortality rate ratios. They're trying to split them into the separate sort of subgroups of age to see whether or not a program has relatively worse or relatively better waitlist mortality, for example, compared to their overall waitlist mortality. So if we go to the next slide, this is sort of specifically motivated because we regularly hear comments about older candidates have higher waitlist mortality, which is obviously true, but all of our metrics, the transplant and waitlist mortality rate metrics, do adjust for candidate age. And so we're expecting older candidates to have a higher waitlist mortality. So if you want to know why you have the waitlist mortality rate ratio that you do, one way you can do that, at least in terms of understanding the effect of your different age subgroups, is just to look at this tab and see which subgroup of age has a higher waitlist mortality rate ratio relative to your overall waitlist mortality rate ratio. So in this example, the candidates with aged between 40 and 60 had a waitlist mortality rate ratio of 1.11, which is slightly higher than the overall of 1.04. It's basically in the same ballpark. So they're quite similar in this example, but they're not guaranteed to be at all times. So on the next slide, so this particular tab is unique to kidney. It's the by ESRD time evaluation, which stratifies the evaluation by subgroups of years since first initiation of dialysis. And we specifically chose dialysis for kidney because it's the primary measure of allocation priority. Obviously, it's not the only way allocation is done in kidney, but it's the primary way. And because of that, we would expect candidates with different years of dialysis at listing to have different transplant rates. And so we want to show what's going on in this particular example. So this tab is generally designed to present the pre-transplant metrics by some measure of allocation priority across all the organs. So the variable by which we're stratifying is actually different for each of the organs. So for in liver, we stratify it by laboratory MELD as the primary measure of allocation priority. And in lung, we stratify by the different subgroups of lung allocation score. Right now, we don't actually have this type of tab for heart transplant, just because they did have a very significant change to their allocation system recently. And perhaps once more time sort of accumulates post that implementation, we might be able to add this tab and functionality to the heart pre-transplant expected workbooks. On the next slide, the last evaluations tab is this custom evaluations tab, which allows the user to look at sort of their own subgroup analyses, and it compares it to the overall evaluations, which are at the top row. So we're going to talk about how you can do this later on in the presentation, but basically if you go about performing your own subgroup analyses, the bottom row will change or update depending on the specific subgroups of interest to you. So one of the really, I think, useful ways available to these pre-transplant expected workbooks is sort of understanding exactly where this number, which is the overall transplant rate ratio, is coming from, because this is sort of like the primary evaluation in terms of the pre-transplant metrics. And so you can see if we just click, and what's useful about these workbooks is that they sort of, all the steps are available. They can be quite complicated at times, but they're available if you sort of work through them in terms of the workbook. So if we click on the cell for the overall transplant rate, we see that it's just this D4 cell, which is the observed number of transplants plus 2, divided by this D5 cell, which is the expected number of transplants plus 2. So this is telling us what the exact equation is for the rate ratio, but it's not actually telling us how the expected number of transplants is being calculated. If we want to know that, we have to go to the next slide and look at what the expected cell is. And if we go to the next slide, this is sort of a more complex Excel statement, but we can see that in Excel terms, it's looking at this tab called Adult TXR and Pediatric TXR to figure out what the appropriate expected is for the overall transplant rate. So again, we have to go to these parts of the Excel workbook to understand specifically how the expected is being calculated. So if we go to the next slide, those cells are specifically in the top left. So in the next slide, the expected, if there's more than one candidate at this program, is going to be taken from this expected row, this 223.22. And that's nice, but if we click on that cell, we can see exactly how that 223 is being determined. And it's just the sum of this H9 to H1008, which is, if we just look over to the middle, is actually just the column of expected for each patient at this program. So if we want to know how the expected is calculated, it's just the sum of all the expected. How do you calculate the expected for a given patient? Well, you just click on the cell for the patient, and it is essentially, this looks complicated, and in some ways it is, but it's also, I think, simpler than you might realize. So the first part is just the baseline hazard. It's the baseline risk of receiving a transplant at a given time. The second part, which is G9, is the days at risk. So basically the days that you're on the waiting list during the evaluation period. And then the last part, which is the complicated part, is just the adjustment that we are making to the expected based on the risk adjustment model. So based on the risk adjustment model, do we need to scale your expected number of transplants up or down? And this is just dependent on the patient characteristics at listing. And it also depends on, and so all these patient characteristics are available in this tab on the far right, and we'll actually have an example later that gets into using some of those patient characteristics to do a subgroup analysis. But for now, we're going to focus on this days at risk, which is this G9 term, the second term. So if we go to the next slide, the follow-up days, which is the days at risk, is just the difference between the beginning of follow-up and the end of follow-up, which sounds simple. And if we go to the next slide, the beginning of follow-up is pretty simple. It is just the time from listing or the start of the evaluation window, whichever is later. But the end of follow-up is actually much more complicated, and we're not going to get into the specific details on how this is determined, partly because it's different for the transplant rate versus the waitlist mortality rate evaluation. But just as an overview, it sort of depends on both the end of the evaluation period, it's a combination of the end of the evaluation period and whether or not your candidate is removed from the waiting list during that period. So on the next slide, if you want to do your own subgroup analyses, then this column, which is on the far left side, column A, include this patient, is the column that you're going to want to use for your subgroup analyses. And as you can see right now, each row is just one, which means that that patient is currently included in the subgroup analysis. And if you don't want to include the patient, you just set this row to 0. So on the next slide, you can do this by either linking the patient IDs, and again, this is a fake data example, so we don't have patient IDs in this example, but in your program's pre-transplant expected workbook, it should have patient IDs. You have to connect those with whatever system you're using and figure out which patients to include. Alternatively, you can use the patient level data that is provided in the workbook. This is limited to the variables that are included in the risk adjustment model, but it does allow you to likely more easily do some of these subgroup analyses. And just as an example, on the next slide, if you wanted to do a subgroup analysis, as an example for type 2 diabetics, so you want to compare the transplant rate ratio at your program for type 2 diabetics versus non-type 2 diabetics, you find this column, which in this given example is AT, and this column is 1 for candidates that have type 2 diabetes, and it's 0 otherwise. So all we need to do is on the next slide is set that A column, the include this patient column, to be equal to AT9, and we drag it all the way down, which should update the entire column of this, include this patient. And you can see on column I and column J that the observed and included is changing dependent on whether or not this patient is included or has type 2 diabetes. So when this patient doesn't have type 2 diabetes, the expected and included is set to 0. So when we go to the custom evaluations tab on the next slide, and this is linking back to sort of how you do your own subgroup analyses, we can see that this particular program has 378 candidates with type 2 diabetes, and that their overall transplant rate ratio, while slightly lower than the transplant rate ratio for all patients at the program, is, I would say, pretty similar. On the next slide, there are ways to do more complicated subgroup analyses. For example, you might want to do a subgroup analysis for candidates with BMI greater than 30, or you can imagine wanting to do some sort of subgroup analysis with BMI. So continuous variables are not directly included in the workbook, but there are linear splines included. And so if you are familiar and comfortable with the definitions of linear splines, then you can do these more complicated subgroup analyses. But again, these are quite complicated and beyond the scope of this particular presentation. So we're not going to get into that today. On the next slide, and this is just basically a public service announcement, the SRTR is integrating a metric for patient mortality after listing into the PSRs in the upcoming summer release. So this says July 2020, but I'm pretty sure the public release has been postponed to August due to the extended data review period from COVID. We are currently previewing the models on the srtr.org website, and we do provide program-specific reports, which are basically the reports that would have been included in the last cycle. And those reports are included on the secure site for programs to review if they're interested. We are obviously open to any comments, questions, or recommendations on the patient mortality after listing metric. We are also actively developing an expected workbook for this metric so that programs can hopefully better understand both how it's constructed and possibly do any sort of subgroup analyses that they're interested in. And on the next slide, with that, I'll hand it over to John to do the question and answer period.
Great, thanks so much, Dr. Way and Dr. Hart, for your presentations. Amy Ketterer on our team is on the line and has been monitoring the Q&A portion. So I don't know if, Amy, if you're available, do we have any questions that we'd like to address?
Yes, absolutely. Thank you, John. And thank you, everybody, for coming in today, and hope you found it very informational. Let's begin, since we have a kind of a short window here to finish up with our question and answer session. So we have some questions for all three of those sections. I'm going to start with the liver tool. For Dr. Snyder, can you be more specific on historic data? What time frame or cohort is used?
Sure, absolutely. So we update the cohort, like I said, about quarterly, and the time frame that's used is a recent 2-year window. And for the different outcomes, recall that the tool allows you to choose, say, 30, 60, 180, 90 days, 365 days. The tool, depending on which time point you've chosen, actually samples different days. So there are more days available in that 2-year window if we look at, say, just 30-day outcomes, whereas the tool samples from fewer days if we're choosing a 1-year outcome. And so if you're running into sample size problems and you're getting fewer than 5 candidates, you may try to select a shorter time period. The reason why that happens is because for 30-day sampling periods, we can sample days that are all approximately 30 days apart. So there's more of those to sample than there are a 90-day or a 1-year period, and where we don't want to have overlapping timeframes where we're looking at the patient experience on those days. So the days that are sampled are included in the methodology tab, but that's the basic gist of it is a 2-year window sampling various days, and the actual days that are sampled are presented there.
Great. Next question. How often is the data that feeds these tools updated?
I can take that. The liver calculator tool is updated approximately quarterly. We try to stay on a schedule, just depending on where the business days fall at the end of that quarter. The kidney calculator we have been updating. It's only been out for about a year and a half, but we've updated it. We're looking at probably a once a year update on the kidney tool, but we don't have a set schedule that we're updating that one on yet. But about once a year is our current feeling on that.
Great. And another question for Dr. Snyder. Can you speak to the sampling strategy for the cohort used in the liver waitlist tool? I think I heard the patients are not randomly sampled. Is that correct? Sounds like I can find the answer to that on the methodology tab.
Correct. Yeah. So hopefully my discussion of the days that are sampled addresses that a bit. We're essentially picking days not at random, but non-overlapping days within that 2-year period. And depending on the time frame the user has chosen, different days are pulled. So you can see all of that within that methodology tab. We're hoping that choosing those days, say maybe 1 month or 2 months or 3 months apart for the different time periods, that sort of their point prevalence snapshots of the waitlist on those days, and then we're following patients forward from that point forward.
Great. And a final one for Dr. Snyder. Will the tools reflect the changes to program operations as a result of COVID-19? All tools, but specifically kidney transplant.
Yeah, it's a good question, and I don't have a firm answer for that yet. We are evaluating what the effect of COVID-19 is on all of these metrics. And so the answer, I think, to that question will be different for the different tools and the different, different metrics we present in our program-specific reports. Dr. Way is leading the analyses for us to investigate how we can best handle the COVID era in any of these tools. And the answer to that might be that we just need to exclude it if it really doesn't reflect a future reality for transplant once the COVID has passed. And so the answers will vary for different tools, but just know that we are addressing it. We are looking at these things and trying to find the best way to handle it. We certainly don't want to be putting out data that are greatly impacted by the epidemic. That might be misleading in terms of what would happen to a patient once this epidemic has passed.
Great. Thank you, Dr. Snyder. I have a question here for Dr. Hart. UNOS, and I believe most transplant centers, use the term increased risk rather than infectious risk. Is there a reason that term was used?
So we include both terms, increased infectious risk and standard infectious risk, partly because we were also trying to help patients understand the difference between the increased risk of a lower quality, high KDPI kidney and the increased infectious risk. It's really hard for patients to separate those concepts. And so we wanted to make it as clear as possible by including the infectious terminology in that. I do know that the CDC is updating those guidelines, and so as the terminology changes, we'll make sure that we update the tool to match, including the descriptions of what's included in increased infectious risk, and to make sure that we're all using the same words.
Thank you, Dr. Hart. And the next question is kind of building on the kidney tool, but it is also for Dr. Snyder. Is there a plan to show the same format as the kidney tool for the liver waitlist calculator, using the tabs with education and then the last tab being calculator?
That's a great question. We've had internal debates about both what the question is proposing, that we would develop modeling for the liver waitlist. We're also considering the converse. Should we provide sampling strategies like we do with the liver calculator for the other organs, the thoracic organs as well? We don't have tools in that area as well. So Dr. Hart is really taking the lead on the development of these concepts with us. And so I think that's something that we are actively debating, as what should be the strategy going forward, and should we try to harmonize across the different organs. We are in discussions about developing tools for the thoracic organs as well, and could do something similar for pancreas and intestine. And the answers may vary depending on the specific state allocation policies, if they're easier or harder to model, or it's sufficient to just present observed data on the waitlist, or we need to go to a more complicated modeling strategy. The kidney transplant, just given the number of variables that are included in that selector box, it's a modeling strategy proved to be better in the kidney example, because the modeling strategy allows us to really get specific, qualities down to specific candidates, whereas the selectors you noticed on the liver tool are perhaps more limited in terms of all of the candidate characteristics that might affect a patient outcomes. So there are pros and cons either way, but that's something we will be actively investigating. And if you have suggestions, we're happy to hear those. Email us at any time.
Just to follow up on that, this is Allison Hart, the additional tabs that are in the kidney transplant decision tool that make it more than the calculator alone, that was actually work done with a separate grant. It's beyond the current scope of the SRTR to do a lot of the user feedback and focus groups and interviews that we did for those tabs. So that's something that could potentially be done in the future, but is a little bit beyond the scope of the modeling that the SRTR usually does.
Great. Thank you, Dr. Hart and Dr. Snyder. I have one more question. Have enough time? It can be for Dr. Way or anyone who would like to answer, but it is in reference to the expected survival worksheets. How often do you update workbooks?
Yeah, I can answer that one. We have a workbook that gets uploaded to the secure site with every PSR cycle. So whenever there's a new PSR cycle, a new workbook will be available to programs. And I believe it is uploaded in the secure release. So
that's correct. So twice a year. They're updated every 6 months. Right? Obviously, the COVID delay here is going to delay this release by a few weeks, but generally speaking, they come out every 6 months.
Thank you, Doctors Snyder and Way. That is all the time we have today. It is 2:00, so we probably should wrap this up for the sake of everyone's time.
Great. Yeah, thank you all for attending, and please check out our YouTube channel for this webinar will be posted in a few days, or any of the past webinars. And as always, feel free to email us, get in contact with us. srtr@srtr.org is the best, and follow us on our Twitter, LinkedIn, and again, the SRTR YouTube channel. We're trying to do a great job of communicating all that we're working on through those channels. Thank you, and stay safe and enjoy the rest of your day.